is Jordan McGreevey, and for this project, I focused on addressing mental and behavioral health care provider shortages in rural Montana. So, for this project, I focused on Montana and specifically rural Montana as my community. Montana is home to about 1.1 million people, but is still one of the least densely populated states in the U.S., spanning over 147,000 square miles, as we know of mountains, plains, and rural landscapes. Nearly half of Montana residents live in rural communities, and 75% of the state's counties have fewer than 5 people per square mile. Traditional industries include farming, ranching, and mining, and these remain vital even as tourism and urban growth expand. But it definitely highlights the challenges and opportunities of serving remote, widely dispersed communities throughout the state. Access to behavioral and mental health services is one of the most urgent public health challenges in Montana, especially for our residents living in rural areas. In 2021, about half of Montana's residents lived in communities that did not have enough mental health professionals, and this shortage has serious consequences. 1 in 10 adults in the state report frequent mental distress, and more than 41,000 Montanans live with a serious mental illness. Substance use disorders are a growing concern. Montana's rates of drug and alcohol misuse are higher than the national average, and drug overdoses rank as the 4th leading cause of injury-related deaths. Sadly, Montana has one of the highest suicide rates in the nation, a statistic that keeps coming up over time, about 29 deaths per 100,000 people. And the risk of dying by suicide is nearly twice as high for those living in rural areas compared to more urban areas. Factors that play into this include social isolation, stigma, culture, and especially a shortage of mental health care providers, particularly psychiatrists, are key factors in contributing to these high rates. And so all of these realities highlight the urgent need to strengthen access to behavioral health services across Montana's rural communities. So access to mental health care in rural Montana is a big challenge. These people live farther away from providers and more metropolitan area where there's more resources. We have cultural norms and stigma surrounding mental health and discouraging those from seeking help. But most of all, there simply aren't enough providers statewide. For example, in 2021, there was 1 mental health provider for every 300 residents in Montana. But if you look at more rural counties, such as Valley County, there was 1 mental health provider for every 740 residents. And this matters because professional treatment works. We know that therapy for depression can boost improvement in depressive symptoms for about 60%, and interventions can cut suicide attempts by up to 30%. So expanding access in rural areas isn't just important, it's critical for Montana's mental health. The Health Resources and Services Administration, also known as HRSA, is a federal department agency within the U.S. Department of Health and Human Services, and its mission is to improve access to quality health care for underserved populations, including rural residents, low-income communities, and medically vulnerable groups. And how it works is it provides funding and grants to states, local governments, clinics, and educational institutions. It supports programs that train, recruit, and retain healthcare professionals in areas with shortages, and it oversees key programs like the National Health Services Corps, which is a loan repayment and scholarship program for providers in shortage areas. It's also known for its HPSA, or Health Professionals Shortage Area designations, that identify areas that are eligible for workforce support based on population. And so in Montana, HRSA contributes millions of dollars in grants to improve rural healthcare and behavioral health programs, but persistent challenges remain. Provider shortages continue, especially in mental health, and recruitment and retention remain difficult in rural areas in Montana. And this is due to HRSA's fragmented and inflexible funding structures and its ability to really address workforce shortages effectively. And so the result is that despite these programs, despite the money and the resources, rural Montanans are still faced with limited access to mental health care. And these gaps are only expected to grow with population changes in the state. So a major administrative challenge for HRSA is its reliance on inflexible and short-term funding structures. Many grants that it provides comes with rigid conditions that dictate exactly how funds are spent and leaves little room for local adaptation or innovation. Furthermore, programs operate on a short 1 to 2 to 3 year cycle, which undermines long-term workforce planning. For example, initiatives like the Behavioral Health Workforce Education and Training Program and the National Health Service Corps are essential, but their strict terms and limited durations make it difficult to sustain progress in rural communities. And this inflexibility contributes to reoccurring workforce shortages and unstable access to behavioral health care. So to strengthen Montana's rural mental health workforce, HRSA needs to move away from their rigid, categorical funding and adopt a more flexible, community-driven, bottom-up approach. Increased flexibility would allow local organizations to tailor solutions to their specific challenges, such as recruiting providers to more isolated areas that need stronger financial and housing or educational reimbursement incentives. For instance, recruiting a provider to a cute little ski town resort like Red Lodge, Montana, that's still a HIPSA designation, is much different than recruiting a provider to live on the High Line or more isolated communities in the east side of the state. HRSA also needs to expand and provide long-term, more stable funding structures instead of these short-term grants. It's critical for sustaining and building programs, retaining staff, and building lasting mental health resources in rural Montana. This proposal directly supports and aligns with HRSA's mission to improve health access and strengthen the rural healthcare workforce. By allowing more flexible, multi-year funding and reducing categorical restrictions, HRSA can empower Montana communities to design solutions that fit their local needs with more long-term sustainability. The recommendations build directly on HRSA programs that already exist, such as the National Health Service Corps. So the proposal is an adjustment or an improvement rather than a complete overhaul. We're not making new programs. We are just increasing the flexibility and extending current grant timelines. The proposal is also politically and financially feasible. It aligns with bipartisan priorities around strengthening rural health infrastructure in Montana and can be implemented by reallocating existing funds that are already there and just adopting expanded or more flexible multi-year grant models. I think implementation could begin within the next 1 to 2 years, and this would involve revising the current funding structures and revising grants to make them more flexible and long-term. And it would be a great idea maybe to start with pilots where these more flexible grant structures and longer funding cycles are implemented in a few communities, and then over the next 3 to 5 years, HRSA could expand the successful models statewide. Success would be measured using clear data-driven indicators. So we're looking at higher rural provider retention rates, reduced behavioral health workforce vacancies at facilities, and also additional metrics like program operations. How long did they survive beyond initial grant cycles? Also, patient access rates, appointment openings or availability, workforce satisfaction, and even outcomes. What are the mental health outcomes and the behavioral health outcomes of Montana, maybe in 3 to 5 years? So, in conclusion, rural Montana faces challenges in accessing healthcare and especially mental and behavioral healthcare. HRSA's limitations now are their current funding structures that are rigid, short term, fragmented, and limit local responsiveness. My recommended approach is that HRSA instill a more flexible, multi year funding structure that allows a coordination with local communities and really targets local incentives. The expected outcome is to strengthen the mental health care workforce, create more long-lasting, sustainable programs, and ultimately improve healthcare access for rural communities.